Thank you all for joining us today for our webinar on Fracture Liaison Service Return on Investment Calculator. I'm Debbie Zeldo, and I am Senior Director of Clinical Programs at the National Bone Health Alliance. And for those of you who don't know, the National Bone Health Alliance was launched in 2010 as a public-private partnership that brings together the expertise and resources of its many public, private, and nonprofit partners to provide a platform to address the issues important to bone health. NBHA currently has 55 members that include 35 nonprofit members, 16 private sector members, and 5 government agency liaisons, which provide a collective reach to over 100,000 healthcare professionals and 10 million consumers. NBHA's vision is to improve the overall health and quality of life of all Americans by enhancing their bone health with a focus on addressing the priorities of the Bone Health Summit National Action Plan to promote bone health and prevent disease, improve diagnosis and treatment, enhance research, surveillance, and evaluation. As part of the 2020 vision, NBHA launched Fracture Prevention Central in March of 2013 to help healthcare professionals and administrators implement a coordinator-based post-fracture FLS model of care to reduce secondary fractures and the associated costs while increasing patient outcomes. There are currently over 3,000 registrants to the site. Fracture Prevention Central provides a wealth of free resources, tools, and materials that we continuously add to, all of which you can use and adapt to your needs. All of the Fracture Prevention Central webinars are also available on demand on Fracture Prevention Central as well as on the NBHA YouTube site. We have several other webinars that are coming up. Obviously, we have today's up there, as well as August 4th, 16th, and October 11th. We hope that you will go to the site and register for those. And then I also wanted to mention a newer program of NBHA, which is our one-on-one consult service, which will connect you with an expert to answer your questions related to the Fracture Liaison Service via phone or email. And when you go on the Alliance NBHA site, you will be able to see the form, fill out the questions, and then we will be able to link you to the expert that will provide the most answers that you need in implementing your Fracture Liaison Service. Just a few logistics before we get started. All attendees are muted. We will have time for a Q&A at the end of the webinar. You can enter your questions on the GoToWebinar panel where it says questions. Feel free to do that as we go through the webinar. Do not wait until the end. And that the webinar is being recorded, and we will be able to send you the link to the webinar recording as well as the slides next week. The webinar will also be available on the NBHA YouTube channel. NBHA has developed the Fracture Liaison Service Return on Investment Calculator with the University of Alabama-Birmingham, Jeff Curtis and Lang Chen, and Research Triangle Institute. Arnie Aldridge and William Dowd are 2 speakers today. After hearing from our members on how important this piece of the puzzle was to make the business case for the FLS. We are so excited to officially release the calculator today and to have Arnie and Bill here to do it. The webinar will provide an overview of the intention and functionality of the calculator, as well as some sample scenarios. As I mentioned before, there will be time for Q&A. It's now my pleasure to introduce our speakers, Arnie Aldridge and William Dowd. They're both from RTI International and are in the Behavioral Health Economics Division at RTI. It's now my pleasure to turn it over to Bill.
Thank you, Debbie, and good afternoon, everyone. As Debbie said, my name is Bill Dowd. I'm an economist at RTI, and I'm happy to be here to present and discuss with you the initial version of the FLS calculator that we've developed along with NBHA and the University of Alabama at Birmingham. Before we get to the calculator itself, I just want to sort of talk a little bit about the purpose of the calculator. if I could get my slides going here. And a lot of this I think will be preaching to the choir to this audience, but just bear with me. There exists a large care gap in among older adults with fractures, in that they don't always get the screenings and care that they need following their initial fracture. And data show that patients with initial fractures or with fractures in general are more likely to have subsequent fractures. So in that way, fractures beget fractures. The FLS, or Fracture Liaison Service, addresses this problem by coordinating care for older adults with fractures to ensure that they get the screenings, they are properly diagnosed, and they receive the treatments that they need. And so given that large care gap that you can see up there on the right in terms of Medicare rates of treatment and testing, this is a very worthwhile initiative. The FLS is a worthwhile initiative. However, in the real world, decision makers in facilities and in practices face budget constraints. So the purpose of this calculator is to provide some statistics and some context around the FLS to help a champion who's really passionate about an FLS help to make a business case for its implementation in their organization. Specifically, the calculators to the costs associated with implementing an FLS program, the revenue that the services that are provided to patients due to that FLS program can generate for the organization, and the impact that the FLS may have on patient outcomes in terms of refracture rates and treatment costs. I'm sorry, costs associated with treating those subsequent fractures. So just to give a little bit of an overview, I'm going to talk through the data and methodology behind the calculator very briefly. We'll then go through in the slides, we'll go through the input procedures for the calculator. We'll outline a sample scenario, and then we'll jump over to the calculator itself, which is based in Microsoft Excel, and we'll enter the data for that sample scenario and look at the output from that scenario together. After that, we'll have some time left for questions and answers. So just to briefly touch on the data and methods, as a calculator, our FLS calculator relies very heavily on user inputs. It's sort of it's more of a template for analysis. It doesn't have any inherent analytical capabilities other than just taking the data that is put into it and producing estimates. So with that said, we do attempt wherever possible to provide default values that can either help guide a user to finding the local data estimate that fits that parameter slot, or can give a fallback option if local data aren't available. The takeaway point from this is that to get the best estimate for your organization, we recommend that you use local data, that is local cost data, local revenue estimates, and local impact estimates, and cost and fracture estimates wherever possible. But we'll walk through very briefly the defaults that are available in the calculator. So for the cost of an FLS, and of course costs break down along the lines of labor and non-labor costs. And for the labor costs, we use average salaries from the Bureau of Labor Statistics for staff that are often tapped to serve as FLS coordinators in an organization's FLS program. For the revenue side of things, this is very heavily driven by user inputs, and you'll see when we get to the input screens the type of information we ask for in the calculator. But for reimbursement rates, we include defaults from the Medicare fee schedules. There's a physician fee schedule and a laboratory fee schedule made publicly available on the CMS website, and that gives us locality-based reimbursement rates for various services that are commonly delivered as part of an FLS program. Treatment impact can be a little bit tricky. In a perfect world, we would have a randomized controlled trial done on an FLS program to tell us what impact does an FLS have on reducing subsequent fracture rates. That hasn't been done, and for various reasons, it is not likely to be done, mainly because FLS programs vary quite a bit from implementation to implementation. So we offer two ways for the user to specify the impact that the FLS will have on patient outcomes. The first is for the user to directly specify the proportion of fractures that would happen without an FLS that would be prevented if an FLS were implemented. And we'll talk a little bit more about that when we get to the input screens. The second uses data from experimental studies of certain treatment options, both optimal supplementation and pharmacologic treatments that do have fracture reduction rates associated with them, to then estimate an overall fracture reduction rate based on the proportion of patients that receive those treatments. So those are the two options we have in terms of estimating the impact of FLS, which is important in order for the calculator to do its estimation. Final set of data and parameter sources speaks to patient outcomes. And this is the part of the project where the folks at the University of Alabama at Birmingham were invaluable to us. They had access to and were very familiar with a data set of Medicare beneficiaries composed of the 100% female sample and a 5% random sample of male beneficiaries. We applied some inclusion and exclusion criteria to that data set to end up with an analytic sample of 418,000. Within that sample, we created 3 cohorts. And these cohorts are designed to deal with the fact that when you're looking at claims data, patients will sometimes appear and disappear over time, or disappear and reappear, as it were, to cause some analytical headaches. So these cohorts, the requirements for inclusion in each of these cohorts is that a patient have data in the data set for 2, 3, and 4 years, respectively, following their initial fracture. And this allows us to get accurate estimates of refracture rates and costs. Now, with each successive cohort, the inclusion criteria is more strict, so the sample size decreases as you go from the 2-year cohort to the 3-year cohort and the 4-year cohort, but you see the sample sizes there on the screen. These are the cohorts on which we did our modeling, which underlies the estimates in the calculator. For each of the individuals in this data set, we use diagnosis and procedure codes to identify fractures by each of 9 fracture sites, which we'll see when we get to the calculator, and we use allowable charges to estimate healthcare costs. Just talking briefly about the estimation of the models that are inside the calculator. And the models are used to estimate both refracture rates and costs associated with subsequent fractures. The first model to estimate refracture rates is a multinomial logit model, with a dependent variable is a 10-level indicator of fractures, where the 10th level is no fracture. And we use as controls in this model 2-way interactions of the initial fracture site, age, and gender. So that model can tell us, for example, what is the probability that a 65-year-old male with a previous ankle fracture will have another ankle fracture in the next 2, 3, or 4 years, respectively, using the cohorts that we talked about on the previous slide. The second model that we developed was a cost model, which is used to estimate the healthcare costs associated with these second fractures. These models are generalized linear models, and they're used to estimate excess costs. And we estimate excess costs by estimating overall healthcare costs for patients without a second fracture by fracture site. So for example, we take the healthcare costs over 2 years of a patient with a hip fracture and compare it to a patient without a hip fracture to get an estimated excess cost, which represents cost associated with that second fracture over that time period. This model has similar control variables, except that it also includes the second fracture site, the baseline cost, which represent the 12 months prior to the initial fracture, and an indicator of a combination versus a single site fracture. Because this calculator we've been referring to it as a beta version, it is an intermediate product. We're still working on developing many aspects of the calculator. There are some things that users should be aware of in terms of next steps that we hope to complete over the next few months. The first is that we need to refine the estimates of the costs. We just talked about the modeling strategy with the cohorts. The current version of the calculator estimates costs based on the entire analytic sample and not the cohort structure. We need to refine those cost models so that they're based on the cohorts that we discussed. The second and much larger issue is that we need to expand the calculator to work with younger populations. As I stated, the calculator is based on Medicare data at present, and we would like to be able to speak to FLS programs that serve patients as young as age 50. So in order to do that, we need to repeat these analyses on a commercial data set on younger individuals and integrate that output into the calculator so that we can make estimates for younger patients. Finally, the calculator currently calculates a return on investment based on the cost of the program which is a function of the staff and the resources used by the program, and the revenue generated by the program, which is a function of the services that are provided and the reimbursement rates that are received for those services. This does not take into account any benefits that would accrue to organizations by helping to reduce future fractures in their patients. And what we hope to do is design a hypothetical shared savings model to take into account the fact that organizations would reap monetary benefit from Medicare and other payers by helping to prevent subsequent fractures in their patient population. So I just want to walk through now the input screens to the calculator in the slide form, and then, as I said, we will look at a hypothetical scenario, walk through entering the data together, and then looking at the results. So the first major set of inputs when you open up the calculator is the initial fracture, and this is sort of the caseload, if you will, for the FLS program at a given organization. There are two options for how to enter these data. What you see on the screen here we call the detailed option, and I've listed it first, even though it's second in the list there, because it's the preferred option. It's the more accurate option. I'm going to jump to the next slide and then come back so we can see the difference. But the simplified option requires that the user input describe their population in terms of demographics, and then describe the number of fractures they've treated over the past year at any of the 9 fracture sites we have listed here. We then take those numbers and estimate expected values for this table under the detailed option, which again we've said is the preferred, which requires that the user input for each demographic category the number of fractures they've treated over the past year. If, for example, you in your organization's FLS program would choose not to include or not to attempt to recruit patients with ankle fractures into the FLS, you could uncheck the box corresponding to ankle here, and the ankle would disappear from this table, and we wouldn't account for ankle fractures when estimating the caseload of the FLS program. The next very simple input is the recruitment rate. One of the main determinants of both costs and revenue is the number of patients that are going to be a part of the FLS program at an organization. We've heard from a number of folks who are involved with FLS programs and that have been in communication with the NBHA that 80% is a good initial target. However, this parameter, like all parameters in this calculator, can be customized. So if you would hope to aim for a higher target right off the bat or a lower target, you can modify this parameter as you see fit. The next set of inputs has to do with the costs, and there are 2 screens here. This part is looking at the FLS coordinator, which is the person sort of responsible for day-to-day operations and interfacing with patients and coordinating care of patients recruited to the FLS program. Based on the caseload that's entered, the calculator estimates an estimated staffing need for the FLS program. In this case, we've entered 400 fractures, and the calculator suggests that half an FTE will be needed to oversee the FLS program in terms of an FLS coordinator. This parameter can be used as estimated, or it can be modified by the user if you feel like you can, if you need more support for your FLS, or if you can manage with less support. The user then would specify the staff type. The options we have are physician's assistant, registered nurse, and nurse practitioner, which are the common staff types that have managed FLS programs in the past. When you select a staff type, a default salary value from the BLS data will appear here, as well as our default fringe benefit rate of 30%. Both of these parameters can be modified if you have local data suggesting that your staff costs are higher or lower than the default value. The next slide is everything else, all of the other costs associated with the FLS, and this is very much a blank slate. It breaks down costs in terms of labor and non-labor and allows you to enter different staff that are whose costs are attributable to the FLS program in whole or in part, and we'll look at an example of that when we get to the hypothetical scenario. It also allows non-labor resources such as supplies and materials, space costs, or equipment, such as if the purchase of a DEXA scanner is determined to be fully attributable to the FLS program. You can include that here as well. It is very fully customizable for the user to enter whatever the costs are that they face in getting an FLS program off the ground. Finally, this section allows for an overhead rate, which can be applied either to labor only or all costs. And that can be input as a percentage into that box right next to overhead rate right here. The next set of input speaks to the protocol, which is a direct determining of the revenue generated by the program. We have what we've done with the protocol is split it into a base protocol and sort of an add-on services or additional procedures and services section, which we'll look at on the next slide. The base protocol is composed of the office visits with the FLS coordinator. And so what the user would do here is enter their zip code and select their reimbursement schedule. And our calculator has 4 default reimbursement schedules, 2 for facilities and 2 for non-facilities, each at 100% and 85% of the physician's reimbursement schedule, or the physician fee schedule. So the user would enter their zip code, select their reimbursement schedule, and hit import protocol, and that information will be populated down here. Now, again, just as with all of the other parameters in the calculator, if this doesn't fit the protocol that you've laid out at your site, these parameters, these rows and columns can be modified as you see fit. So if every 6 months, you have one every 3 months, you can add additional office visits or subtract office visits or add other completely different items to this list. It's just the defaults are limited to these types of things for the base protocol. The next screen, as I said, is that are offered that are made available to FLS patients. Again, the user would enter their zip code. They would select a service from this portion, from this box here, and the services included here include office visiting services, laboratory procedures, physical therapy services, and there are a few others. And when we get to the calculator itself, we'll look at it. Unfortunately, the drop-down doesn't work. But you select your procedure and your reimbursement schedule and hit import procedure. Populates the first row here. You edit as you see fit, and you have your full protocol between the base protocol and the additional services, representing the services that FLS patients get that lead directly to revenue generated by the FLS program. The final set of inputs is the FLS impact. And we talked about that when we were going through the slides. The 2 options that we have are this one, which are direct estimates of fractures prevented, where based on the initial fractures that you enter and the models that we've run that underlie the calculator, the calculator will estimate the total number of fractures expected at each site. So say, for example, you expect 100 ankle fractures over the next 2 years. By entering 2.2 in this field, you're saying that you expect that 2.2% of those 100 fractures will be avoided if an FLS is implemented at your site. So that's the interpretation of these parameters. The other FLS impact is to base it on common treatment options, where you would specify the percentage of FLS and non-FLS patients that receive treatment options, whether it be optimal supplementation or pharmacological treatments. The limitation here, obviously, is that it doesn't take into account other things like more prompt imaging or physical therapy may also help a patient avoid subsequent fractures, which is what, although it is prefer that the direct estimates be used to get the best outcome. We'll jump over to the calculator and we'll look at a sample scenario of a hospital-based FLS program with 400 fractures in the past year, and we'll stick with the 80% default recruitment rate into the FLS. In terms of costs, this program is staffed by a nurse practitioner as the FLS coordinator at 1/2 FTE. There's also an administrative assistant at 1/4 FTE, with space costs and supplies and materials costs, and on other costs, on total costs. In terms of the protocol, they use the base protocol at the 85% fee schedule at the facility rates, and then they could conduct additional labs and physical therapy respectively. And we'll go through how to enter that into the calculator. Finally, the assumption in terms of impact is that is by between 2 and 8% by site. So I'm going to jump now to the calculator, and we will walk through the input really quickly, and then we'll have plenty of time left for question and answer. The first option is just to enter a name. So we'll just call it sample hospital. And then, as you saw on the slide, we went through the different options for inputting initial fracture data. Normally, when you download this calculator from the NBHA website, this will be blank. However, at this point, I've entered in 400 fractures. You see the sum was 400, so you all didn't have to sit and watch me enter numbers here for 5 minutes to make sure they added up to the right amount. As I said, you could also choose the simplified option where you would fill in demographic characteristics and total fractures by site. But we're going to go with the detailed option here. As I said, we'll stick with the default, excuse me, 80% recruitment rate for the FLS in this sample scenario. We said the FLS program was staffed with at 50% FTE, which is the default, which is the estimate made by the calculator based on the 400 fractures. The calculator does suggest an estimated half full-time equivalent to support the FLS coordinator. However, as I said, if you wish to use a different value, you can simply update this parameter to whatever you would like, and it will modify the staff cost accordingly. But as I said, we will stick with the default estimate of 0.5. Now, as I said, when you choose a staff type, a salary estimate based on BLS data appears here. The nurse practitioner, the national average, 101,000, and we will use a default 30% fringe rate. In terms of other costs, we did have on the slide, we were going to have an administrative assistant at a quarter FTE at a salary of $35,000, and we will use the same fringe rate of 30%. We said that we had space costs at $1,000 and supplies, materials at $3,500, and we said that there would be a 15% overhead rate applied to total costs. So that's how all of that is entered into the calculator. In terms of the protocol, we said that we were going to use a 85%. The FLS coordinator is an NP at the facility rate, so we'll hit import protocol. As I said, you can freely edit these fields as much as you want. You just need to specify all of these different options so that the calculation did. But just to drive home the point that although we have these default values in here, you are not beholden to stick to them. You're free to use whatever most closely represents your protocol that you hope to implement at your organization. The additional services here, we can see I've already entered, I said on the slide there were going to be some labs and some physical therapy services at 3 and 6 months respectively. I've gone ahead and entered some, but just to show, you're going to enter the zip code, you select a service. Let's say we wanted to add a DEXA scan to this protocol at the selected reimbursement schedule. You hit import protocol or import procedure. It gets added to the list. Let's have to fill in the timing of the expected timing of the service. Maybe the DEXA scan happens right away. And the percentage of FLS patients to use that service. And the reason we ask for this information is that we're interested in incremental revenue generated by the FLS. We can't attribute all revenue to the FLS. We have to capture the additional revenue, just like we wouldn't attribute all costs to the FLS. We can't attribute all revenue to the FLS. So we might say, for example, that 100% of FLS patients get a DEXA, while 25% of non-FLS patients get a DEXA, sort of reflecting the care gap that we saw on the first slide. Okay, and the last set of info that I said on the slide, we were going to assume that the fracture prevention rate, 8% depending on the fracture site. I'm just going to enter some values in here. And I will show you the alternative way that we can account for impact, which you saw on the slide, which is to, again, input it with these four treatment options, which you estimated fracture reduction rates associated with them. And that's it for the data entry. We now have a report. It's ready, done already. I've actually saved this report to a PDF, which is what this button here does. So and we'll sort of walk through the report together, look at the output, and then we will get to any questions that you all may have. The report deals with the inputs. It just sort of summarizes the inputs that you put in. Fracture input procedure. We input 400 fractures at a recruitment rate of 80%. We had our nurse staffing. We also had an administrative assistant. Non-labor costs included space and supplies and materials. On the 400 patients and the 80% recruitment rate, we had 320 patients recruited into FLS. We used the base protocol physician fee schedule in the facility, and we used direct estimates for our FLS impact data. This over here describes the patient population in terms of the second panel of the report, deals with costs and revenue. So the FLS coordinator salary, after taking into account how many FTEs, their salary, and the fringe rate, comes to almost $66,000. Other labor costs and non-labor costs are added up to get a total cost of $93,000 for the course of the year. Revenue, each patient is expected to generate $752 over the course of 4 years. For 1 year, the entire program generates $188,000. When you compare the total cost to the incremental revenue, you get a return on investment of for every dollar invested into the FLS. Hypothetical scenario input, return on investment to the FLS program. The FLS program can be expected to generate $1 in additional revenue. The report then speaks to patient outcomes in terms of fracture frequency. So by site and by year, we can look at the fractures that would be expected without the FLS, with the FLS, and then the numbers of fractures prevented. So, for example, if we look down here in the lower right-hand corner, we see that without FLS, in the initial population of 400 patients with fractures, without an FLS, we would expect 78 additional fractures over 4 years. But with the FLS and with the impact estimates that we input into the calculator, we would expect 3.65 of those fractures to be avoided. So down to 4.5 fractures. Finally, the fracture cost outcomes describes the total cost associated with the fractures and the savings so we see after 4 years, the total fracture cost is nearing $4 million. However, with an FLS, I have to save about $185,000 in terms of cost of treating those fractures. The final 2 pages of this report are just there to copy over the protocol information because it is so pivotal to the values in the first 2 pages of the report. We wanted to include it so that it didn't get lost on the input screen. So this is just a copy of the information we entered into the protocol screen. So that is the report generated, and it's identical to the report tab on the Excel file. It's just nicer and easier to work with a PDF file, I think, instead of a version. So that concludes the walkthrough of the calculator. I'd be happy to answer any questions at this time.
Great. Just to remind everyone, this is Debbie. If you have a question for Bill or Arnie, please type it in to the question box down on the right-hand side. You'll see a little arrow, and we'll be happy to have that question answered for you. The first question that we have is, when do you anticipate expanding the age range to include persons over 50 years of age?
So we're currently aiming to do that by the end of this calendar year. We have to find, we think we have identified a data source, but we have to get access to those data and then run the models. So we're tentatively targeting the end of this year.
Great, thank you. Okay, the next question that we have is there a spot for buy and bill treatment options? And if so, does it have the capability of keeping track of what's purchased under Medicare Part B and how many of those treatments were dispensed? Let me know if you need me to repeat any of that.
Yeah, well, I'm sorry, Debbie. The first part of the question, is there an option for?
Yeah, I'll do it piece by piece. Is there a spot for buy and bill treatment options?
I'm still not
clear on what that means. Okay.
Yeah, I'm not.
We'll see whether. Okay, that's good. Let me. I'll move on to the next questions and get back to that one. Okay. How did you derive the values of fracture reduction that you use for each fracture type?
Sure. The impact. Okay. Those are assumptions. Those are necessarily assumptions because there are no data sources out there that tell us an FLS program will reduce fractures by this percentage. So there have been some retrospective studies within ACOs and other organizations that have looked at, after implementing an FLS, certain fractures like hip fracture rates in their entire treatment area have fallen, but there have not been any, randomized controlled or otherwise even quasi-experimental looks at FLSs in particular. So we're sort of stuck with either using an assumption with a direct estimate, or using the treatment option here, which we can sort of derive an expected reduction rate based on these treatments, which have been experimentally studied. And of course, two other alternatives. I think we recognize that ideally we would have a more concrete answer for that, but at this point, we really don't.
Great. The next question that we have is, in the impact area, how do you account for those patients evaluated but that do not need treatment based on DEXA or type of fracture?
Yeah, that's the last question in a way, in that this calculator sort of deals with a cohort of patients. So obviously, within the some of their initial fractures will turn out not to be associated with osteoporosis and probably will not need further. On average, when we look at when we're estimating, when we're making an assumption about the impact of the FLS fracture reduction rate, we wouldn't have much of an impact on those patients in particular because they're not going to get those additional treatments. That's a very good point. However, by entering, as I did, into the revenue section, 100% of FLS patients getting all of these treatments, that's my hypothetical scenario sort of fell short there because obviously, as you point out, some patients would need all of these. So that's a very good point. But in terms of the impact, our estimate of the impact of the FLS sort of takes into account the cohort and not individual patients' situations.
Great. Our next question is, are the costs of pharmacologic therapies accounted for in the calculator?
The cost of delivering pharmacologic therapies are not directly accounted for in the calculator. They can certainly be added to the other cost section under non-labor costs.
Okay, I have a little bit. Okay, great. Before you can start to use the calculator, you must first obtain 1 year of retrospective chart reviews of the demographics and fraction information at your facility, ? So they're wondering how much data you need in order to start filling out the information in the calculator.
So we suggest using a year's worth of data to get a decent estimate of. So it's all a function of how well you think the prior year will represent future years. If you feel confident that you can look back 6 months and then extrapolate up to a year as well, what we want is for the input section to represent as best we can an estimate of the number of fractures that you will treat over the coming year. And we feel like the best readily available estimate of that is to use the past year. It's not a perfect estimate, mind you, but it's probably the best that most folks can do. If you have a better estimate of that, or if you think you can just extrapolate based on a shorter retrospective review, that's perfectly fine.
Do you have any suggestions for people who have not monitored this population before?
I'm not sure. I don't think I'm best suited to answer that question. I think there are other folks, even probably on the line, that can answer that a lot better than I could.
Okay, great.
Yeah, this is David Lee. I guess what I would say is that, I think pulling that retrospective data, like Bill said, if it's 6 months or a year, to show, really the bulk of, what folks are coming in and fracturing, certainly starts to make the case, especially as you see many folks that have fractured that, got casted, had surgery, and that was the end of the conference. To find out what that care gap might be in your individual institutions in terms of 100 fracture patients, 100, and if that average of 80-85% is a good goal in your FLS that you're going to be able to capture through an FLS, so kind of showing that kind of where you are now, where you think you could get if you implement an FLS, and I think that starts to show the patient population that is appropriate for this follow-up and treatment for those folks that need it. But I think that's the best way to start to make the argument to really show your care gaps, especially as they relate also to the national average on, say, that HEDIS measure, which is the measure that 6 months after a fracture, older women age 65 to 85 get either screened and or treated for osteoporosis.
Great, thank you. Actually, David, there's another question that I think goes your way. How do we access the calculator, and when will it be available?
Yeah, so we're going to upload it this April. We kind of wanted to make sure that folks kind of were taken through it before they got a chance to mess with it, especially with no kind of explanation or instruction. So we're going to upload it this afternoon. We also will include the walkthrough as a separate shorter video that's kind of more tutorial. But I think what we'd also like to get, once folks get a chance to access it themselves and play with it, is certainly get feedback, such as what we've gotten today on, things that might be missing or potential codes that we may want to include, as well as, Bill kind of stated, the great thing about it, I think, is that you can toggle on and off whatever applies to your given setting. Obviously, very different, hits your hospital or institution or not. Some of the labs, if you're doing, physical therapy and all kinds of other things, whether that is a revenue source or something happening externally to your program. But certainly want to use this almost to crowdsource the best version of this calculator based on everyone's experience, so at the end it is all-encompassing as possible. And then certainly, as Bill said, this is really the beta version. One will be making modifications and tweaks in this, what is really more fee-for-service type of calculator, but then moving toward, in the by the end of the year, kind of that that version of the calculator that really speaks to the more value-based model, because certainly from the financial bottom line perspective, the revenue generation and ability to get additional resource out of your FLS is much greater with new models than a kind of typical fee-for-service. But we wanted to get this out now, and then certainly, even wanted to get it out to get this is, the kind of 65 plus. We'll be working before the end of the year to get fee-for-service calculator out, and we'll continue to, re-release new versions of these refinements and data available.
Great. The step-by-step guide that you mentioned, David, they're asking whether it will contain written instructions on what we did on today's webinar, or what exactly it will contain.
Yeah, I think initially it will be, really truncating the part of Bill's presentation in video form, but we can I think what we wanted to do is actually kind of more frequently asked questions, but I think we could almost, transcribe each of the major input fields into a little manual. But I think, initially it will be the calculator itself. It will be this video, which, usually we get within a couple of days after any webinar in terms of the on-demand version that we can upload to YouTube. So maybe another week or so before we have kind of a manual, but really feeling that walkthrough, if you're, looking at it on one screen, listening to Bill, or, of the screens that he showed you earlier today, that should really help walk you through it. But certainly want to get additional questions so that as we develop this frequently asked questions document and additional documentation, we can certainly make sure that it's clear as we can.
And let me just add, David, that the calculator is instruction as to what to enter in which fields and how to use certain features of the calculator. So as you're going through the Excel file, you'll see, a few paragraphs before each major panel of input section, so that get a little bit of context around what you need to enter there.
Great, thank you. We have one last question. What software will be needed for its download?
Microsoft Excel. It's been tested on the more recent version of Excel. It should work on older versions as well. No special software needed.
Wonderful. Well,
you will. I'm sorry, Debbie. You will have to enable, when you open up the document, it will ask you if you want to enable content, because there are some macros in the file. You will have to click enable content, but every version of Excel can operate those macros. So yeah, just Excel, and make sure you accept those macros when you open up the document.
Okay, wonderful. Well, I really want to thank everyone for joining us today. And most importantly, thank Bill and Arnie for going through the calculator. As I mentioned earlier in the webinar, that the recording as well as the slides will be sent to everyone who's registered for the webinar early next week. If there are any additional questions that you have regarding the webinar, feel free to contact Bill or Arnie, or always feel free to contact myself, debbie.zaldo@nbha.org, as well as David Lee, which is david.lee@nbha.org. Thank you all so much and have a wonderful afternoon.